hope that you all remain well. My name is Charles Snyder, and on the behalf of my co-chair, Craig Lillehei, and our entire Professional Development Committee, we would like to welcome you to APSA's second annual Top Educational Content, or TEC Talks. As always, we would like to thank APSA and the Journal of Pediatric Surgery for their support of these talks. TEC presentations were patterned after the popular internet TED Talks. Our intent was for each speaker to condense what we needed to know on their topic using minimal slides and with a 15-minute time limit to maximize interest and to increase retention. This format was first used at our 50th annual APSA meeting in Boston last year, albeit with some trepidation. The presentations were all simply outstanding, and they were very well received. A bit of background. Our most important charge as the PDC is to collect, review, and prioritize the knowledge gaps for our profession. These are identified from a variety of sources, but most importantly, via the hard work of all the APSA committees, and we thank you. These knowledge gaps are then addressed in a variety of ways, including expert questions and discussions available in the pediatricsurgerylibrary.com or through the NAT, through Todd Ponsky's Global Cast reviews, through articles of interest, or by way of the Sunday Spaced Learning courses. These TEC presentations are the primary venue for our top 4 educational topics each year. Our only ask of you, the viewers, is to identify and submit any knowledge or practice gaps that you identify to us. We need and we value your input. Simply mark KG or knowledge gap in the chat box or email to think@eaapsa.org. We do depend on the wisdom of the crowd. The next speaker needs no introduction, at least for those of you who follow him on Twitter, Facebook, TikTok, Slack, Orkut, AOL Online, or MySpace. Jack Dorsey calls him the master of social media. Todd Ponsky is professor of surgery at the University of Cincinnati. He is going to discuss how to avoid gas embolism and how to manage it should it occur. Todd, the virtual podium is yours.
Todd Ponsky. You know, over the last couple of years, APSA has done something fantastic. They have identified these critical topics, these critical new and important issues that we're realizing, and they keep continually explaining this in different forms of media to the APSA membership about these ideas. And one of them is this concept of gas embolism during infant laparoscopy. This is a very new topic for me. In fact, I didn't hear anything about this about a year or so ago. And about 2 years ago, I started hearing reports of people saying that, oh yeah, there's more and more of these cases of infants getting a laparoscopic pyloromyotomy and dying from a gas embolism. And I'll be honest with you, I didn't really believe it, and I was skeptical because I had never heard of such a thing. But more and more people keep saying that this has happened to them. So if you look through the literature, there's almost nothing out there. There's literature on gas embolism during laparoscopy, but not much on infants. So a lot of what we're talking about is anecdotal. So here's the theory. The theory is that this happens upon insertion of the trocar, and that when you take a trocar and you insert it through the umbilicus, you get the entry into possibly the umbilical vein, and you're insufflating air into the umbilical vein. Now, maybe just a skive, it may not be a full entry into the vein, but maybe it tears the vein enough that it's like a one-way valve where air can get in and blood doesn't get out. Who knows? No one knows, but that is the working theory right now. So how would this present? How would you know? Well, you'd be operating on a baby that has a normal, healthy baby. You start insufflating, and all of a sudden the baby either has a cardiac arrest or anesthesia tells you that they're losing their end tidal CO2. And at that point, the assumption should probably be that it's very likely that the child has an air embolism from the laparoscopy. So why does this happen, and how can we prevent it? So last year at APSA, Steve Rothenberg presented a series of cases that he had heard about of patients that had had this, and his answer had to do with entry. He supposes, his theory is that the cases he's heard about were when the surgeon entered in the middle of the umbilicus. Now that's how I do it. I make an entry bluntly through the umbilicus, no knife needed. You bluntly enter, there's no bleeding, you insert the trocar, you insufflate, and do your case. So his theory is that those are the cases when this happens and you're so close to the umbilical vein, so that the answer is to make your incision below the umbilicus, that those few millimeters away will decrease the risk of entry into the umbilical vein. Now, he talks about making his incision at the lower edge of the umbilicus, so the incision is in theory still hidden, but this is his proposal, which somewhat does make sense. Last year, Liz Byerly presented from the PDC about her theories on what moves you can make to try to mitigate the risk of this happening. And she talked about a couple of things. Number one, confirm trocar placement before insufflating. So put your trocar in and then put your camera in and see that you're in the belly and then insufflate. So I actually, as soon as she presented that last year, I switched to doing that. The second thing was, and this was a cool trick, I definitely was not doing this before, is to evacuate the room air out of the tubing and start blowing CO2 out of the tube before you connect it into the trocar, insufflating the abdomen. Her point was that the nitrogen is actually what causes most of the risk of these air bubbles. So if you can evacuate the nitrogen, evacuate the room air out of the tube, blowing CO2 and then connect, it mitigates some of the risk to the child. So what do? So you're operating and the baby all of a sudden has loss of end tidal CO2 and they decompensate. If you suspect an air embolism, which you should after that happens, the key is to get the right side of the heart up in the air. So you turn the patient head down and right side up. With that, the air bubble, in theory, should rise up out of the pulmonary artery. So the other possibility that you could do is put in a catheter and aspirate out through a jugular or subclavian and aspirate out the air in the heart. That's a little tricky to do. You theoretically could do that under echo, but it's probably pretty hard to get all of that in time. So this is a little trickier, but the maneuver of putting them in Trendelenburg and left lateral decubitus is a good idea. So that's it. Now, what were the key takeaways about what we just learned? Number one, this is a real thing. Most of us have never heard of it or never had it happen to us, but others are starting to note about it. So keep it in mind that it's real. Second thing is, we don't know how it happens, but here are some measures that may help to decrease the risk of it happening in your patients. Number one, enter the belly in front umbilically instead of through the middle of the umbilicus. Number two, look before insufflating. Put the camera in the trocar, make sure you're truly in the belly before you actually insufflate, and make sure you're not actually in the umbilical vein or in the soft tissue. Finally, run CO2 through the tubing before you actually connect it to the trocar. And then, if you suspect it happens, turn the baby with the right side up and head down, and that should move the bubble up to the apex of the heart, mitigating the blockage of blood flow through into the pulmonary vasculature. I hope this helps. This is a very new and important topic, and I think it's critical for us to be aware and some very easy measures to both prevent and treat. Thank you.